So when we look at second-line treatment for non-small cell lung cancer, it has changed with the recent approvals of frontline immune therapy. So outside of patients with an autoimmune disease, with an organ transplant, or some other contraindication receiving immune therapy, most of our patients now are receiving some form of immune therapy as their initial treatment, unless they're a non-squamous patient with a targetable mutation or fusion or other actionable alteration. And I want to emphasize that if you have a non-squamous lung cancer, we should be doing molecular testing, and oral therapy would be the first choice if you get an actionable alteration. So I think that, the good news is we have better frontline treatment and patients are living longer, especially with the combinational immune therapies. The flip side of that is that we're kind of back to standard second line regimens like docetaxel or docetaxel with ramucirumab that we're not that excited about. And I think that is one of our major areas of unmet need in non-small cell lung cancer now, is finding a way in the post-IO setting to reignite the immune system and get additional prolonged immune responses, to continue to look for new molecular targets and find ways to enhance the second line chemotherapy options like docetaxel. So I think that the use of the second line therapy is become more limited, but for a good reason, that we have better initial treatments that include immune therapy. But the second line setting now is really a challenge. I do think that there will be new immune options in the second line. We're learning more and more about how cancers are able to evade the immune system. So people will now generally get some form of IO therapy first. And if the cancer progresses, then obviously, if there was an initial response, then it's evaded the immune system somehow. So I think there's a lot of ongoing scientific evaluations that are letting us understand, is this downregulation of MHC1 to avoid the immune system? Is it local tumor effects with increase in Treg cells or MDSCs? Is it other changes in the tumor microenvironment? And I think that we're rapidly progressing to understand how immune evasion occurs. And there are a lot of pipeline therapies that are now available that'll let us test different strategies for overcoming the secondary immune resistance. So I think that's where things are headed. And I think the clinical trials are ongoing. So hopefully we'll find some new strategies that will let us reignite the immune system in patients where progression has occurred, and get secondary and tertiary immune responses that are helpful.
When we look at second-line therapy, I think some of the big characteristics determining our approach are the prior treatment delivered and patient comorbidities and performance status. When we look at performance status, comorbidities, it really drives the suitability of further therapy. Our role as an oncologist is not to see how much treatment we can deliver. It really is to help patients. And if patients have very poor performance status, if they're very weak, I know they're not going to derive the benefit from further therapy. And my efforts, the best way to really help that patient might be to focus on symptoms or more of a hospice-based approach. But for patients who have a good performance status, there are an increasing number of options. Our previous second-line therapy had been docetaxel-based treatment, either alone or in combination with ramucirumab. It depends on what initial treatment was given. For example, if pembrolizumab alone or atezolizumab alone were given, or if dual checkpoint inhibitors such as nivolumab and ipilimumab were used in the frontline setting, my second-line regimen would really become platinum-based chemotherapy. Now, whether to continue the checkpoint inhibitor in the setting of second-line platinum doublet chemotherapy is a question that the INSIGNA trial will look at to see if continuation of a checkpoint inhibitor beyond progression provides any value or only cost and toxicity. Right now, our standard approach after progressing on immunotherapy alone, either mono or dual checkpoint blockade, would be platinum doublet chemotherapy, histology specific. But if chemoimmunotherapy were given continuously, then our second line option really docetaxel-based treatment, though we're certainly always exploring clinical trials, novel immunomodulatory agents, and different strategies to really recapture those long-term benefits.